Okay. Hi, everybody. Sorry, we had a few technical issues before we got on. My apologies. So my name is George Minawata. I'm a volunteer pulmonologist for the MAVEN Project, and I'm going to be your moderator today. Thank you all for attending and being part of MAVEN Project. I especially want to thank the Cherokee Health Systems, who've served the East Tennessee communities since 1960 for hosting today's session titled Cholesterol Management Guidelines and Update. Before we begin the talk, a little bit about our speaker, Dr. Craig Sadur. Dr. Sadur was an assistant professor of medicine at the University of Colorado Health Sciences Center and chief of endocrine unit at Denver General Hospital. Then after 9 years of private practice in endocrinology, joined Kaiser Permanente, Northern California, where he practiced clinical endocrinology for over 24 years and received the Career of Caring Award for exemplary physicians. Dr. Sadur, the mic is yours.
Great. Thank you. All right. And let me get this here. Okay. All right. Okay. Thank you so much, Dr. Minawata, and thanks to everyone for your patience as well as being here. Because today is a topic that is so exciting, so pertinent, and keeps changing. So with that, we'll go through the cholesterol management. The guidelines came out a few years ago, and there's been some updated guidelines and some relatively recent information. So with that, this guideline came from the American Heart Association in conjunction with the American College of Cardiology, and subsequently there were further guidelines for specific patient populations from the Endocrine Society. So today's educational objectives are the following: identifying which patients could benefit from therapy for their dyslipidemia, and defining those different patient populations for the stratification of their risk, and individualizing treatment to optimize management, whether it's primary or secondary prevention of cardiovascular disease. So the agenda, we'll go through some cases. We'll touch on the non-pharmacologic measures that have been shown to be so helpful, risk stratification of those different patient populations, use the online risk calculator, go through the special populations that have their own unique situations, and drug therapy individualized management, and end it with the information resources that are helpful for clinicians as well as patients. Let's dive into the cases. So the first one, we've got a 20-year-old healthy Caucasian female, no history of diabetes mellitus, hypertension, dyslipidemia, tobacco, or any family history of atherosclerotic cardiovascular disease. On exam, her weight's normal, her vital signs are normal, the exam's unremarkable. So we all get the feeling like, great, young, healthy, appearing patient. The history is essentially negative. Well, what do we do? Well, with that, we want to counsel her for lifelong healthy lifestyle, good nutrition, weight control, exercise, staying tobacco-free, and stress management. And start measuring the lipids, even at her young age of 20. Measure the lipids, ideally fasting because you get a more accessible triglyceride. But if she can't or won't do fasting, do non-fasting. Take whatever you can get. And with the nutrition, there's various places. One is the American College of Lifestyle Medicine. There's been more and more evidence that plant-based nutrition helps. And for a patient, it doesn't have to be all or none. You can counsel the patient, like, maybe consider one meal a week plant-based and sort of put the toe in the water. And people can find out that it's tasty, it's not expensive, and it's something that is definitely healthy. The American Heart Association is one place where there's moved more together in terms of exercise. Nationally, it's recommended for patients to do at least 30 minutes, at least 5 days a week. And that's been shown to have multiple benefits. And of course, tobacco cessation. The NIH has their National Library of Medicine that has been very helpful for patients to discontinue. And stress management, here's a picture of Herbert Benson, cardiologist who had the foresight that maybe there's something to stress. And so decades ago, he started the Mind Body Medical Institute and wrote the relaxation response, which is still very pertinent for clinicians and patients. Okay, let's do case number 2. So we've got another young patient. We've got a 25-year-old Asian male, and blood pressure 130/85, increased abdominal girth, fasting blood glucose 101, high density lipoprotein cholesterol 39, triglycerides 151. So at first glance, not too bad. You know, blood pressure, labs, increased abdominal girth like so many people in our country have. But the numbers don't look bad. So what do? Lifelong healthy lifestyle. And the concern is metabolic syndrome. And if you can prevent it from occurring, great. If you can reduce some of the issues that make up the syndrome, great. And so here's a cartoon of the 2 main adipose distributions. We've got on the left the shape like an apple, android, because it tends to occur mostly in men, but it can occur in women. So we've got mainly adipose abdominal distribution. And on the right, we've got the shape like a pear, which has been called gynecoid because it's more common in women, but can occur in men. And this is the one that's more gluteal. And the reason this is important in terms of cholesterol is the shape of the apple, the android, is more atherogenic. There's something about the abdominal adiposity. So with metabolic syndrome criteria, it takes 3 or more of the following to meet the criteria for metabolic syndrome, which has been shown to increase the risk of atherogenesis. So the first is the waist of 40 inches or more in men or 35 inches or more in women. And this was decades ago that this was set up. But long after that, it was shown that for Asian patients, the numbers should be changed to 35 inches or more in men, 31 inches or more in women. So with our patient, we know he has increased abdominal girth. It wasn't measured, but it's possible he met the criteria. Triglycerides of 150 or higher. He did meet that criteria. He was slightly above, but also you may have a patient who's on fibrates. So if they're on fibrates, they meet the criteria for elevated triglycerides because fibrates are so effective in lowering triglycerides. HDL cholesterol, he met the criteria. His was a little low, so below 40 in men, below 50 in women. And again, if they are on fibrates and or niacin, then they meet the criteria for having HDL as part of the syndrome. Blood pressure, 130/85 or higher. He was at that level. So he met the criteria with these 3 measures, and maybe the waist. We don't have those numbers. So he's got metabolic syndrome. And to cap it off, he also had a blood sugar that was over 100. So very common, very important, and it helps lead us to how we can best help patients. So the lifelong healthy lifestyle, you want to start assessing with these 2 patients, start assessing at age 20 years. And if you can primarily prevent metabolic syndrome, great. Otherwise, try and reverse it. Okay, a third case. We've got 50-year-old Latina female. Now, ethnic populations have certain propensity toward atherogenesis, and Latinos are one of them with metabolic abnormalities such as type 2 diabetes, hypertension, are increased in incidence, and those are major risk factors for atherosclerotic cardiovascular disease. And sure enough, she's had a history of myocardial infarction and a cerebral vascular accident. So she's already got the disease. And you look at the LDL cholesterol that she has, and first glance, not too bad, 90. So with her, what would you do? You think about if she were your patient. Well, again, lifelong healthy lifestyle, it's the cornerstone of treatment. Eliminate whenever possible, or at least reduce risk factors. high intensity statin. She's got very high risk of atherosclerotic cardiovascular disease. She's at a really young age, has already had two events. And it wouldn't be a surprise for many patients who have this high risk atherosclerotic cardiovascular disease to need something other than a statin, so multiple treatments. And consider the LDL goal of less than 70. Remember, hers was 90, which again, we would have a lot of patients, we'd love them to have an LDL as low as 90. But because of her significant medical problems, the goal is even lower. And that's been the whole trend over the number of decades about dyslipidemia. The numbers have shown getting more and more aggressive to get those LDLs lower and lower has been shown to add benefit. So LDL cholesterol in clinical atherosclerotic cardiovascular disease. Lower LDL, you want to lower it with the high intensity statins, or at least the maximum tolerated statins to lower that risk. And high intensity statins are atorvastatin 40 to 80 milligrams once daily, or rosuvastatin 20 to 40 milligrams once daily. And the atherosclerotic cardiovascular disease includes cerebrovascular accident, TIAs, coronary artery disease with stable angina, acute coronary syndrome, arterial revascularization, peripheral arterial disease, aortic aneurysm. So a number of people could have one or more, and that's their gateway into having clinical atherosclerotic cardiovascular disease, which puts them on a pathway for trying to individualize therapy. So the statin intensities, we talked about the high intensity, and here it is again. It's atorvastatin 40 to 80 milligrams once daily, or rosuvastatin 20 to 40 milligrams once daily. And that has been shown consistently to lower the LDL cholesterol by 50% or more, highly effective. Moderate intensity will lower the LDL by about 30 to 49%, and those are atorvastatin and rosuvastatin at reduced doses, or simvastatin 20 to 40 milligrams, lovastatin 40 milligrams. Those are all once daily, and fluvastatin, if that were the choice, was 40 milligrams BID. Low intensity statins are designed to lower the LDL by less than 30%. Pravastatin 10 to 20 milligrams, or lovastatin 20 milligrams each once daily. This is rarely needed, but let's say you have a patient who's had a myocardial infarction who, for whatever reason, has an LDL of 50. Well, you still want to lower it. You want to give them the benefit of a statin, because statin does help stabilize endothelial tissues and lining. So you want to give something, but those would be the patients that are low intensity. But far and away, most patients are going to need at least moderate, and many need high intensity statins. Something to consider is the CYP3A4 inhibitors, because they are key when you have a patient who you want to put on a statin who is already on a statin. So simvastatin, lovastatin, and to a lesser extent atorvastatin are metabolized by CYP3A4 pathway. So if you have a patient with the CYP3A4 inhibitors, various calcium channel blockers such as zoltiazem, it increases the plasma statin levels, which could increase the myopathy risk. So for patients who need to be on a medicine that's a CYP3A4 inhibitor, you might consider rosuvastatin, because the CYP3A4 pathway in those patients is pretty minor. So just something to consider. So for very high-risk atherosclerotic cardiovascular disease, it's defined as patients with multiple events. And that was our patient who had the myocardial infarction and the cerebrovascular accident. So she had those, the myocardial infarction and the CVA, but it's also if there's been acute coronary syndrome within the past year, peripheral arterial disease with an ankle brachial index of under 0.85, amputation or past revascularization, amputation due to arterial disease. So if you've had multiple events like our patient did she's got the criteria for a very high-risk atherosclerotic cardiovascular disease. If you've had one of those, let's say coronary artery disease, and if you've had the one major event like CVA, and you have a high-risk condition, then you would fit the criteria. Well, what are those high-risk conditions? Defined as age greater than 64, familial hypercholesterolemia, which is actually pretty common in our population, preceding coronary artery bypass graft, diabetes mellitus, hypertension, or chronic kidney disease with the estimated glomerular filtration rate of under 60, like so many patients have. These are high-risk conditions for developing atherosclerotic cardiovascular disease. So the very high risk for future events, it's recommended to get that LDL below 70. Again, our patient had it at 90, but we want to be more aggressive, get it down at least into the 60s. And for a lot of patients, not so much her, but a lot of other patients, to reach that goal, not only a statin, it wouldn't be a surprise for many patients to need a second drug, such as ezetimibe, which has been around for many, many years. Okay, let's do another case. We've got a 30-year-old Pacific Islander. Pacific Islanders are another ethnic group that have increased risk of metabolic abnormalities such as hypertension, dyslipidemia, hyperglycemia. So he's already, we're concerned about the possibility. And sure enough, he's got genetics that didn't do him a favor in his particular case. His father had a history of myocardial infarction. His maternal uncle has a history of angina. So he's got the double whammy on both parts of his family tree. He's got atherosclerotic cardiovascular disease. And he's got an LDL that's impressively high. His LDL cholesterol is 190. Okay, young guy, feeling well, concerning family history, concerning LDL cholesterol. Think of him as your patient. Imagine what you would do. You probably got this gestalt that this is concerning. So with that, you want to check his diet, check his meds, and you want to test him. You know, he's got a whoppingly high level. So you want to test for hypothyroidism, test for nephrotic syndrome, even like a urine dipstick for protein, and see if he's got cholestatic liver disease. Pretty easy test to screen, but ones that have been associated with significant hypercholesterolemia. And again, lifelong healthy lifestyle, always step one. And you want to eliminate, whenever possible, or at least reduce his risk factors. And he's going to need a high-intensity statin treatment. And we're shooting for a goal of under 100. And to go from 190 to under 100, and we don't, know what his response is going to be, it wouldn't be a surprise that you would need to add a second drug for lipid lowering in addition to the statin. So he's got severe primary hypercholesterolemia, defined as an LDL at least 190 or higher. Commonly, it's heterozygous familial hypercholesterolemia. The homozygous are really unfortunate. These are rare, fortunately, but these kids, adolescents, and young adults frequently don't live very long. And you can see whoppingly high LDLs like 400. And that's a completely different situation that requires much more aggressive therapy. But far more commonly is someone like this young gentleman who's got the LDL that's high, but not sky high. What's always impressive for me to remember is it's a 20-fold greater risk of a cardiovascular event to have an LDL 190 or higher than if the LDL was 130, 20 times the risk. So when you lower them to an LDL, and it's not even goal, 130, but to lower them, you have done a great benefit for the patient who now has a much improved outlook for the future. So to treat with statin, you want to lower the statin at least by 50% with the secondary goal lowering it below 100. And fortunately, the medicines are available now that can do this. If it's still above 100, again, consider adding a second drug. The most common would be ezetimibe. Okay, let's do another case. So we've got a 42-year-old Black female. Again, Blacks have increased likelihood of developing the metabolic problems that lead to atherosclerotic cardiovascular disease. And sure enough, this patient has type 2 diabetes. But fortunately for her, there's no family history of atherosclerotic cardiovascular disease. She doesn't smoke, her blood pressure is normal, and on exam, her weight's normal, and the rest of the exam is unremarkable. So she's got some things definitely going her way. So what do you do? Sounds familiar, but again, I always have to remind myself, start with the healthy lifestyle and continue to monitor for risk factors. It's very common. She's young, she's 42, but it's very common for patients later in life to develop hypertension, for example, and you certainly don't want her to start smoking, but maybe someone in her family will now have the diagnosis of atherosclerotic cardiovascular disease. So you want to keep monitoring her and optimize her diabetes control. Diabetes control has been shown particularly help with microvascular complications like retinopathy, nephropathy, but there are studies that show macular vascular, such as coronary arteries and cerebrovascular disease, have been helped by improving diabetes control. And checking the lipids, fasting optimally, but take whatever you can get. And try to get the LDL below 70. And as a starter, you can give a moderate intensity statin, but you're going to measure after that and see if you need to adjust the dose, but it gives you a starting point. Okay, case number 6. A little older, this gentleman, than the woman who we just did, 60 years old. He's also Black. He has type 2 diabetes, as she does. But unlike her, he's a smoker. He's hypertensive. He's got a family history of atherosclerotic cardiovascular disease. His exam is pretty unremarkable, including his weight. So what do? We do the healthy lifestyle counseling. Tobacco cessation, as we all know, improvement. And this may be the one golden moment for him that, okay, with atherosclerotic cardiovascular disease looming as a possible risk, now's the time to stop smoking. Hypertension control, vitally important. Optimizing diabetes control, as mentioned with the previous patient. And checking the lipids, preferably fasting, and consider a high-intensity statin. He's more worrisome than she was. He's got more going on. He's got his diabetes, his tobacco, his hypertension, his family history. So for patients with diabetes, age 40 to 75, so starting middle age to older, excuse me, if the statin's 70 or higher, to give a moderate intensity, if the LDL is 70 or higher, give a moderate intensity statin. And the moderate intensity statins, as a reminder, lovastatin 40 milligrams, pravastatin 40, simvastatin 40, atorvastatin 10 to 20, rosuvastatin 5 to 10, pitavastatin 4 milligrams. Those are all once daily. And overall, if you look at populations, well tolerated for the vast majority. But if you have diabetes, a multiple risk factor like the gentleman we just did, or age 50 to 75, as he was, it'd be reasonable to give a high-intensity statin to decrease that LDL by at least 50%. So as you can picture, there's more going on with him. It's not a surprise that more aggressive therapy is recommended because it's been shown to be beneficial. So the LDL cholesterol goals, if you have diabetes already and you have atherosclerotic cardiovascular disease, to go to a high-intensity statin and to decrease the LDL at least 50% from baseline. And then this has been shown, the LDL goal should be even lower than we've been talking about. Before, we've been talking about getting it down 60s or lower. Here it's getting it down below 55. Again, the data has borne this out. And so it wouldn't be unusual to need, in addition to a statin, a second drug, such as ezetimibe or one of the PCSK9 inhibitors, to meet that goal. Now, here's something that's been relatively recent. You have a patient with type 2 diabetes and diabetic retinopathy. As we know, so many patients have diabetic retinopathy, and this can be background diabetic retinopathy, something that needs to be followed, is not imminently dangerous at that moment, but diabetes and with retinopathy, it's recommended to consider fibrates in addition to statins to reduce retinopathy progression, regardless of the triglyceride level. So we're all used to considering fibrates for the significant hypertriglyceridemia. But this is saying, even if you get a triglyceride of 100, you know, but you have a patient with diabetes with retinopathy, consider fibrates because they've been shown to do better. But if you have a patient already on statin and you're going to give a fibrate, the fibrate of choice is fenofibrate. Another consideration is you've got a patient with type 1 diabetes, and you're going to be looking at whatever the cardiovascular risk score is, and we'll go over that. If you have a patient with type 1 diabetes who's 40 years or older, considering statin, because they've already had, most people with type 1, as we've seen, are younger. It's not absolute, but most are. And many of them have had diabetes for over 20 years. So you get a 28-year-old who developed it at age 7. He or she has had an exposure to the major risk for atherogenesis. So at that point, even young people think about statin therapy. If they've had microvascular complications, as we've mentioned, these are common: retinopathy, even background, nephropathy, could have some albuminuria, but still have good renal function. Obesity. Now, obesity in type 1 is certainly the minority, although it's more common now than it was years ago. And especially if you're intensively treating with insulin, which is really the goal at this point, to try and reduce other complications, those are patients that consider statin. And if you've got this high triglyceride, low HDL, that's a very atherogenic lipoprotein. Those are small, dense, and highly atherogenic ones. So that's a pattern we see a lot in type 2, but you can see it in type 1, this high triglyceride, low HDL combination, which is concerning for the possibility of getting atherogenesis. So with type 1 diabetes, LDL cholesterol is the primary target for lipid-lowering therapy. Consider treatment if the LDL is greater than 70. And as you've seen, so many people have LDLs more than 70. So you may end up using a lower intensity statin, but to get them below. Statins should not be used in women who are pregnant or trying to become pregnant because of the concern of teratogenicity. Type 1 diabetes with chronic kidney disease. With chronic kidney disease stages 1 to 4, even 1, consider a statin irrespective of any cardiovascular risk score, and you're trying to reduce the cardiovascular risk. So type 1 diabetes, as you can see, there's a number of added considerations, if not indications, that have accrued over the years to go, this patient would probably benefit from a statin. So with type 1 diabetes, consider statin if the LDL is greater than 70. Think about renal clearance. So pitavastatin, pravastatin, rosuvastatin have partial renal clearance, but atorvastatin, fluvastatin, lovastatin, and simvastatin are cleared by the hepatic pathway. So you don't have to worry about renal clearance if you have a patient with significant renal insufficiency. All statins require dose adjustments in chronic kidney disease, except for atorvastatin and fluvastatin. So, again, I have no financial interest in this, and generic, atorvastatin has been around for decades, and with generic, and if the patient has the insurance for it, Medicaid in your area, as so commonly, atorvastatin is highly potent. You don't have to worry about adjustments. Ezetimibe may be needed and can be added to a statin to lower the LDL even further, and you don't have to adjust the dose with chronic kidney disease. So that's nice. Okay, and this is from Lisa Tanik of the Endocrine Society. She talked about particularly women and pregnancy. Statins, you should consider discontinuing at 1 or 2 months prior to the desire for conception, okay? And certainly if a patient is on a statin and is found to be pregnant, discontinue the statin right away. And women of reproductive age who are on statins should be counseled to be on reliable contraception. All right, case number 7. A 50-year-old Native American. Native Americans, like Blacks, like Latinos, like Pacific Islanders, have an increased risk of developing the metabolic abnormalities that are risk factors for developing atherosclerotic cardiovascular disease. But she has no family history of the disease. She doesn't smoke. She has normal blood pressure. She has no diabetes. She has no history of dyslipidemia. So all that sounds good, except she hasn't been tested. So we've got to check her. So lifelong healthy lifestyle. You want to continue monitoring for risk factors. It's good she hasn't had it, but hopefully won't get it. To check her lipids to see where she is, to see if she's 70 or higher. And do the calculation. And we're going to dive into this. It's the 10-year atherosclerotic cardiovascular disease risk of 7.5% or higher. So what's the likelihood in 10 years that a patient will have a cardiovascular event of some sort? And if it's higher than equal to or higher than 7.5%, consider a moderate intensity statin. So if you've got the patients age 40 to 75 without diabetes, we did the ones with diabetes, but without diabetes, it's clinician provider shared discussion, the risks, the benefits of treatment. Reviewing the risk factors, smoking, hypertension, LDL cholesterol, A1C if they have diabetes, and to calculate the risk by the. And there's many places. There's a American College of Cardiology, American Heart Association tool. It's free of charge on the internet, and you can get it. And if the risk is greater than 7.5% over the following 10 years, it's worth considering statin therapy. Here's the risk calculator. Easy to fill out. Put in the age, the gender, the race. Now, right now, it's white, black, and other. Hopefully, before too long, it'll be more nuanced with different ethnicities. You put in the systolic, diastolic pressures, total cholesterol, HDL, and LDL. Notice they don't have triglycerides. So you could do a non-fasting panel and get this. But if they're hypertriglyceridemia to the level of 400 or higher, the lab may just say couldn't calculate LDL and they won't have an LDL. Now, some labs will do direct measurement without the calculation and that'll work, but many don't. History of diabetes, yes, no. Smoker, current, former, never. On hypertensive treatment, yes, no. On statin, yes, no. On aspirin, yes, no. So the data should be readily available to calculate. Okay, so case number 8. We've got a 52-year-old Indian male. No family history of atherosclerotic cardiovascular disease. He's got psoriasis. Okay, for us non-dermatologists, psoriasis, okay, a lot of people we see have psoriasis. We don't think too much of it. His estimated glomerular filtration rate is 50, so he's got some renal insufficiency. So what do you do? Well, lifelong healthy lifestyle, always step 1. Continue risk factor monitoring. And check the lipids, preferably fasting. All sounds familiar. And to calculate the 10-year atherosclerotic cardiovascular disease risk to see if he's 7.5% or higher. If he is, consider a statin. But let's say he's below the 7.5%. Is he out of the woods? Well, there are these factors known as risk-enhancing factors. And they're not the classic ones, but they've been gaining prominence. Family history of premature atherosclerotic cardiovascular disease. We've seen this. Just think about the patient you've had that says that his or her family, there's been people who've had coronary artery disease, cerebrovascular accidents, peripheral arterial disease, and they were in their 40s, their 50s. So you get this gestalt. That's not good for this patient. This patient has genetics that are potentially concerning, regardless of what the cholesterol is. LDL cholesterol that's persistently 160 or higher. So not to the level we saw with that gentleman who was 190, that bingo put him in the familial hypercholesterolemia area, but this is a concern. Metabolic syndrome, like we had that earlier young patient, chronic kidney disease. Now here it is. For women who have had a history of preeclampsia or premature menopause, defined as earlier than age 40 years, they have this risk enhancing factor that would be part of the mix to assess them, like, should they be on pharmacologic therapy? Possibly. Chronic inflammatory disorder, such as rheumatoid arthritis, HIV, and there it is, psoriasis, which is considered part of the inflammatory disorders that sort of tilt people toward these atherosclerotic cardiovascular disease concerns. And high risk ethnic group, and he is South Asian. So we see this. There's particular, as with the Blacks and Latinos, we've got increased concern just by ethnicity. And a triglyceride level, not sky high, but persistently 175 and up. So when you get this kind of mix, at least one or more, you start to move toward the area of being concerned and possibly prescribe medicine. So for the guidelines that came out not too many years ago, it really helps to focus on these 4 major benefits, okay? This will be almost all the patients that you need. Who needs to be on treatment? Obviously, ones who already have the disease, coronary artery disease, cerebrovascular disease, peripheral arterial disease, they definitely need it. But the ones like we saw in that young fellow with the LDL of 190 or higher, they should be on medicine. Those with diabetes, again, diabetes of all the risk factors, that's the one that's the red flag waving the hardest. Ages 40 to 75 and an LDL greater than 70, it's treating sooner rather than later. And the group that has the LDL of 70 or higher, but they've got the calculated risk of a 10-year event occurring 7.5% or higher. So those 4 groups be the ones that you would have with stratification, individualizing treatment to get them on therapy. And you want to use the LDL levels to assess efficacy and whether or not they're taking the medicine. Use the LDL to guide whether or not you need to add a second agent. So for people who have the disease, excuse me, you want to have secondary prevention. So if they're 75 years or younger and they have clinically disease for the atherosclerotic cardiovascular disease, you want to go to a high intensity statin. If they don't have the disease, but they're very high risk and the LDL is 70 or higher, despite the maximal tolerated statin, you want to add ezetimibe first because it's been around for decades, it's inexpensive, and it's effective. But if for whatever reason you need more, there's the PCSK9 inhibitors. They're recommended rarely because patients who would have to be at very high risk because they're very expensive. Now, if you end up needing to go to it, you want to go through all the early steps of treatment because most of the time that's all that's needed and it works and you're done in terms of getting patients on the right medication regimen. But if all that doesn't reach the patient to get in goal, the PCSK9 inhibitor is there. And depending on the insurance, including Medicaid, you've now strengthened the case to say, we've done everything. We've gone through all the other basic, simpler, less expensive, and now we're stuck with this relatively rare circumstance. For patients 75 or older who have atherosclerotic cardiovascular disease, consider initiating or continuing moderate or high intensity statin. Age, as we've seen, is physiologic. There's a lot of youthful octogenarians, and they would certainly merit being on therapy. And as mentioned at the bottom in yellow, as of the last few years, the American Diabetes Association guidelines recommend for patients who have diabetes and have already atherosclerotic cardiovascular disease, roll up your sleeves even more, try and get that LDL down even further to below 55. Triglycerides, if an adult has a fasting triglyceride level of over 500, it's recommended to go after that pharmacologically in addition to diet and exercise. Because when you have a fasting level of over 500, postprandially, it's expected to be in the over 800 to over 1,000 range. So they've got circulating chylomicrons, and that is a risk for the potentially dreaded complication of pancreatitis. So omega-3 fatty acids can help with triglyceride lowering. If you have patients on statins and their triglycerides are over 150, so not necessarily sky high, excuse me, and either they have the atherosclerotic cardiovascular disease or they have diabetes plus 2 additional risk factors, it's recommended to consider adding icosapent ethyl, which is pure EPA, to reduce that risk of cardiovascular disease. So on statins, triglycerides high, have the disease, or diabetes plus something else, consider adding EPA. And the brands, you can get over the counter, but if you're going to give higher doses, the brands that can give 1 gram pills are Lovasa, Vascepa, Epanova, and the recommended dose is 2 grams BID. If for whatever reason EPA is not available or accessible, you could give a fibrate such as fenofibrate. So there's more of an appreciation for adults with the endocrine disorders, and there's many endocrine disorders out there that lead to dyslipidemia that would call for treatment. And it's recommended that you get a lipid panel, ideally fasting for the assessment of triglyceride levels and to calculate that LDL cholesterol. So even at age 20 and beyond, it's recommended to get lipid panels. Thyroid function, a key point in terms of lipids. If you've got hyperthyroidism, it actually tends to help the lipid panel, but you definitely want to treat the hyperthyroidism because it's got potential complications, numerous. So you want to get people euthyroid. But if you looked at the lipids while they're hyperthyroid, get them down to euthyroid and then repeat the lipids to see if they have dyslipidemia, because now that's more interpretable now that they're euthyroid. Conversely, if they have overt hypothyroidism, by definition, a TSH greater than 10, consider treating the hyperlipidemia once they're euthyroid. In other words, their hypothyroidism may be causing their dyslipidemia. Get them euthyroid, repeat the lipid panel, and maybe it's normal. You don't even need to treat the dyslipidemia, but you'll see. Subclinical hypothyroidism, defined as TSH under 10 with associated hyperlipidemia, consider L-thyroxine, which is the recommended drug of choice, treatment to decrease the lipoprotein levels. One caveat with this is don't overtreat. So you're going to give, if they're running a TSH, let's say consistently 8 with normal free thyroxine and they're dyslipidemic, sure, they may get a little bit of benefit by becoming biochemically euthyroid. So give them a small dose of L-thyroxine. Give them like 0.025 milligrams or 25 micrograms once daily. You don't want to cause iatrogenic hyperthyroidism with a TSH below normal because that has its own complications, arrhythmia, skeletal, but tiny dose may be the trick. Polycystic ovary syndrome, the most common endocrine abnormality in adult women, is commonly associated with dyslipidemia. So you want to check fasting lipids to assess the cardiovascular risk. And hypertriglyceridemia is the most common lipid abnormality, but they're also prone to type 2 diabetes, obesity, hypertension. So suggested steps in risk assessment. If the patient has established atherosclerotic cardiovascular disease or longstanding diabetes, you're done. You don't have to assess the risk anymore. They've got the disease. But if they don't, you calculate the 10-year risk with the calculator. And you want to assess for the presence of risk-enhancing factors. A word about Cushing. So if someone has Cushing syndrome or is on high-dose chronic glucocorticoid therapy, like so many patients are, or has acromegaly or hypothyroidism, those are risk-enhancing factors. Just one word about Cushing syndrome and acromegaly. Endocrinologists are not the ones that find this. these are patients in primary care clinics. And when they have concern about them, then they get referred to endocrinologists. So we evaluate them and treat them and get them on there. But you folks are the key for that. Anecdotally, when I was working in a cholesterol clinic, we had a nurse who came to me about one of the patients. She goes, this is a patient, it looks like she's on prednisone, but she's not taking any that she says. And I said, okay, well, let's arrange, a consult and such. So she was referred to me. When I walked into the exam room, this nurse was absolutely right. The patient had florid Cushing's, and it turned out to be an adrenal tumor. So if you get a patient that looks like he or she's taking prednisone, that's worth at least considering the possibility of Cushing's syndrome. Acromegaly, if you look at someone like Andre the Giant, that's someone who may have acromegaly. And, reaching out to endocrinologists, we're happy to do this at MAVEN Project. We'll be happy to help with the evaluation and, if need be, treatment. But if you uncover that, you are that patient's hero. If there's borderline to intermediate risk, the 10-year calculated risk of 5 to almost 20%, there's a coronary artery calcium score that can be done, particularly if the patient's younger than 40. And in many places, the cost is about similar to EKG, but it's variable. And then to have that patient clinician risk discussion, there's a lifetime risk calculator. So not just the 10-year, but lifetime, to get an idea what would be their chance over the period of a long time of having high cholesterol. And, discussing pros and cons of lipid lowering treatment. Steroid abuse commonly is associated with low HDL. If you get a patient with whoppingly low HDL, under 30, especially if they don't have simultaneous hypertriglyceridemia, consider anabolic steroid abuse. Super physiologic levels of androgen, lower HDL levels. Transgender, in trans women, trans men, past or current gender affirming hormone therapy, assess the cardiovascular risk, use the calculator. For trans women, a conservative approach is to use the cis male category. And for trans men, use both the cis women and cis men category, see which is higher. Basically, you don't want to miss a patient who has risk of developing cardiovascular disease, so you want to treat sooner rather than later. And if there's a greater than 10% cardiovascular risk, consider aspirin therapy to prevent disease, according to the U.S. Preventative Services Task Force. Now, you've made the right move. You've assessed the patient. You've got the patient on the right treatment. Now you want to monitor. So you repeat the lipids anywhere from 4 to 12 weeks. I'm simple-minded. I just do 8 weeks, 2 months. And that's after starting it or any adjustment in dose. And repeat it at least yearly, just to make sure things are staying where you want it to be. And in patients at very high risk, adding the non-statin drugs as mentioned to get that LDL below 70. Non-statin meds, we've talked about ezetimibe, well tolerated. The bile acid sequestrants have been around even before the statins were around. They can cause some GI symptoms, decreased drug absorption, but occasionally you get a patient who doesn't want anything that's absorbed, and this is something that can work. It does have an effect. Bempedoic acid, effective but expensive. Inclisiran, one of the new kids on the block, expensive. And we've talked about the PCSK9 inhibitors, very effective, very expensive. So in conclusion, atherosclerotic cardiovascular disease risks drop with lipid management. Treatment significantly improves outcomes. The candidates for treatment to decrease the risk are people we already know have the disease. LDL, very high. Diabetes, starting at middle age, and as we said, with type 1 with many factors. Ages 40 to 75 without diabetes or known atherosclerotic cardiovascular disease, but a 10-year calculated risk of 7.5% or higher. Special lipid treatment considerations for people with diabetes with even mild retinopathy, type 1 diabetes with the things we talked about, age, disease, duration, microvascular disease, obesity, metabolic syndrome, chronic kidney disease, hypertriglyceridemia, thyroid dysfunction, polycystic ovary syndrome, steroid abuse, transgender. These are all populations that have their own dyslipidemia issues and considerations. So in summary, lipid abnormalities are common. Screening is important. Lifestyle is a cornerstone. Treatment is individualized. Medication is usually very well tolerated. With endocrine disorders, you want to get the fasting lipid panel. Treat the patients with type 2 diabetes and other cardiovascular risk factors with statin in addition to lifestyle. For type 1 diabetes, again, age 40 or higher. Thyroid, we talked about, it's a consideration. You want to reevaluate when they're biochemically euthyroid. Cushing syndrome, and the most common is going to be patients on exogenous glucocorticoids for their rheumatoid arthritis or asthma, whatever it is. And evaluate and treat lipids and other cardiovascular risk factors in women who have early menopause or the preeclampsia, like I mentioned. So in conclusion, atherosclerotic cardiovascular disease risk drop through lipid management. Treatment significantly improves outcome. You will be greatly helping your patients. Here are the resources if you want to dive into the guidelines, both through American Heart Association, Endocrine Society. The American Diabetes Association, American Heart Association has good patient education material. The risk calculators are available free of charge. And Dr. Minowata will be getting you these slide sets, so you will have it available. For patient education, Endocrine Society has Learn Your Lipids, American Heart Association Move Together, NIH Tobacco Cessation. For nutrition, there's the 4-Leaf Guide to Vibrant Health, a very readable book. Forks Over Knives, which has a website, a book, and a documentary. American College of Lifestyle Medicine, up to date, has stress, patient education information. A special appreciation to Dr. Minowata, who at the top of the hour and will be joining us again. Thank you so much. Kristen Talbot, our program coordinator, Dr. Einstein, our director of physician engagement, Shirley Severe Talon, and Jonathan Lewis. Jonathan, one of our IT people who came in, saved the day in terms of getting this up and running. And all these folks have the hard stuff. I do the easy stuff. They tell me where to go at what time, and here I am. So with that, let me open it up to questions. All right.
Thanks, Dr. Sadur. There's a long list of questions in the Q&A. There are a couple in the chat. Let me just go through the chat. There was a question about case 5 and a risk, I think, of pregnancy. I think you addressed that towards the end with the statins, but Pal Monsieur, if that's incorrect, please raise your hand or add some clarification. There's a question about what LDL level, if any, would you consider decreasing a statin dose?
Yeah, that's a really important factor. And long story short, early on, we said, what's too low a statin? What's too low an LDL for statin? And there is no study that gives evidence of below this, you should avoid, and above this, you can give. We know that if someone has severe illnesses, let's say cachexia from malnutrition, from cancer, or end-stage liver disease, it wouldn't be a surprise to see very, very low LDL. And at that point, lipid management would not be their main concern. But you look at the studies, and a lot of the LDL averages have been like 60, which means, sure, there's going to be people in the 40s. If I had someone in the 40s, I would be okay. 30s, if they were doing well. 20s, I would get a little nervous. But again, there's no guidelines with that. There's no floor that we have.
Another question was in the chat was there's another calc called Prevent that's said to be more accurate than the ASCVD update that's more accurate than it's in some updated guidelines. Any comments on that about the Prevent calculator?
I don't as far as head-to-head studies, there may be some move toward it. Again, the biggest guidelines came out 6 years ago, and it wouldn't be surprised if on the next one they may give credence to others. But I can tell you in the national meetings that have been in this year, they are not saying go away from American Heart Association, American College of Cardiology, go to others. But that's why research is done. We're going to keep an eye on that in the future.
Another one in the chat is how come they don't allow for an HDL greater than 100 in the calculator?
Yeah,
That's an
I know.
outlier, I would assume.
Yeah, right. Very rare. And we do see those occasional patients and, tip the hat to them, like, where do you get your genes? I'd love to get some. But yes, in the old days, they used to use an HDL to LDL or HDL to total cholesterol ratio. Those have gone, the ratios have been sort of moved to the side, and people have gone through LDL, which has been the benchmark for a lot of the studies. So I would still use LDL, but I would tell the patient, this seems definitely to be in your favor, but there's no study that has shown that I'm aware of high HDL, high LDL, not treat, they do okay without treatment. So you still want to use LDL. So pretend the patient for the calculator, use the highest level that they'll allow you to calculate.
Okay, let's go to the Q&A part. So if someone has hyperlipidemia, but a coronary calcium score that's very low, so their risk for a cardiac event is low, does that change your management? I would assume it
Yeah.
doesn't.
Yeah, that's an interesting point. So, if you get a score of 0 with the coronary artery calcium, you could make the case for withholding or delaying statin treatment. And this is always an if there are other risk factors are absent. Shouldn't be a smoker, shouldn't be have diabetes, no strong premature atherosclerotic cardiovascular disease in the family. If they had that, I would say, I don't care what your coronary artery calcium score is, you've got high risk factors, high risk. But if they have this negative factor and their coronary artery calcium score is 0, you could make the case for delaying it, making sure they risk factor management, and come back at some point to the coronary artery calcium. There's no data on do it in a year or 5 years, but I would tell the patient, keep doing all the right things.
Okay. Any comments about measuring lipid particle size?
Yeah. A real interesting part of that. There have been studies looking at lipid particles, so not just the LDL, but the LDL particle numbers, as well as the LDL size, as well as things like apoprotein B. So people have looked at these other parameters, and they're not widely available. They're not as inexpensive as the lipid panel. So they're of real interest to people who, follow lipid research. But there may come a day where we look at ApoB more than LDL, but that day hasn't come yet.
Another question about LDL greater than, I think it's 190, raising the risk of atherosclerotic cardiovascular disease 20-fold. Is there any data around the associated risk of metabolic syndrome?
No, none that I'm aware. And as you saw with the metabolic syndrome, LDL is not part of it. It's HDL, triglyceride, glucose, blood pressure, and abdominal waist size. So I would still be concerned. So you can have people that are slender, normal glycemic, normotensive, and have very high LDL. So they don't have metabolic syndrome. So metabolic syndrome, the way to think of it is it's another concerning pathway that some people may take toward potentially getting atherosclerotic cardiovascular disease. And another pathway is the LDL being isolated in its amplitude.
Another question is, do statins induce mitochondrial dysfunction? Do you ever recommend CQ10 when starting statins? And if so, at what doses?
Yeah, the coenzyme Q10, um, there was some early, not rigorous data that showed maybe they help, and then there was some follow-up data that not really helpful at all. So the literature is weak and inconsistent. So it's not been recommended to go on to it. If you had a patient who was super enthusiastic about it, I wouldn't say no, but there's really not good evidence to recommend it.
Okay, and let me just see. What's your experience with the risk of metabolic syndrome imparted by aromatase inhibitor use?
Interesting question. I'm not aware of a study that's looked at that. Um, I don't know. I would certainly, for people on aromatase inhibitors, they're going to be followed for whatever reason they're on it. And certainly with metabolic syndrome, it's recommended blood pressure. We do this yearly for patients who are followed up. We're looking at the lipid panel at least every 5 years. Certainly people higher risk like diabetes, we're going to do it every year. But that's what.
What in terms of subclinical hypothyroidism, you said TSH less than 10. Is that irrespective of the free T4 level, or would the free T4 level come into play there into your
Yeah.
evaluation?
Yeah. Most patients have thyroid panels that make sense, and a minority of them have thyroid panels that just look strange. And for the ones that just look strange, there may be something else going on. It could be a non-thyroidal illness. It could be a lab assay issue. It could be a patient who's on thyroid hormone therapy, but taking it inconsistently, or there may be some interfering agent with gut absorption. So the vast majority, so by definition, subclinical hypothyroidism is defined as TSH above normal, but under 10 with a normal free T4. So that's going to be far and away the most common. But if you have a free T4 that's decreased and you have a TSH that's not particularly high, there may be something else going on, like another medication or potentially hypothalamic pituitary.
For the patients who have who've got an elevated aldolase or CK, and they're on a statin, but they're not on any of the meds that interact with statins to raise the risk of myositis. What do you do? Are there statins that are better, have a lower risk? Irrespective of the interaction with the CY3P. Some people claim that Pravachol has a lower risk overall. Yeah. And then related to that, there's a question about, higher doses of Pravachol, 40 or 80. You don't mention that.
Yeah, really good question. So statins, as we've seen, have potential muscle symptoms, if not complications. If you look at the vast majority of patients who are taking it, they tolerate statins beautifully. There is a small minority who have trouble with muscle aches, and they're real. Now, of those people, the amount who get into trouble, and the trouble would be rhabdomyolysis, where they have not just myopathy, they have myositis to a significant degree. So if you have a patient who is talking about muscle aches, take it seriously, measure a CK, make sure it's not 40,000. And if it were that case, I would definitely stop the medicine. Excuse me. I would look at creatinine. I would assess them for volume. Some of those patients need to be hospitalized. To put it in perspective, if you have 1,000 patients who are going to be with diabetes, 750 of them were worried about cardiovascular conditions that it's going to be the most common cause of death. And if you're talking about who gets into trouble with statins, it's 3. And of the 3, that's probably overdoing it. It's probably 1. It's rare, but it does occur. Now, if you have a patient who, for whatever reason, is having mild muscle aches and is doing okay, and the CK is normal, you go, okay. For that, someone you could switch, and for whatever reason, we don't understand this, one statin may be better tolerated than another. And the person who brought this question up very rightfully talked about pravastatin, which actually has a different metabolic pathway. So I would go through the different statins. If atorvastatin is a problem, rosuvastatin, simvastatin, etc. But usually you'll find one that works, that doesn't cause symptoms. Pravastatin is one that would be the last statin that may be the one that works. And it's not as potent milligram per milligram as atorvastatin or rosuvastatin, but you can get benefit. For the patients who just can't tolerate it, the one option is to give statins, but not every day. I would find the statin that works the best, and you could start off once a week, and generally that's well tolerated, and you can go up to twice a week, and that's generally well tolerated, 3 times a week. And let's say 3 times a week that's as much as they can tolerate. You go, okay, lowering the LDL has benefit, and you can give that, and if need be, add the second agent to that.
And what about 40 or 80 of pravastatin as a dose? You mentioned 10 to 20 in the slide.
Yeah, you can go up higher. Absolutely.
Yeah. Okay. All right. And should vitamin D be checked if there's myopathy from statin? Is deficiency a risk factor?
Well, it's interesting. It's not part of the protocol. Like if you're on statin, you better be checking vitamin D. But a vitamin D deficiency, which is pretty common, has a lot of extra skeletal effects, and one of them is muscle. So it's pretty easy to test, relatively inexpensive. And if they're shown to be particularly severely vitamin D deficient, you may have uncovered something that's worth checking and treating.
And how about a healthy male, 77 with 10-year risk greater than 7.5%? Is it true that there's no evidence of benefit over a certain age?
The studies have gone up. I mean, clearly the studies have gone up to 75. It's not that older patients don't benefit. We just don't have the data. But if I had a patient who was 77 and is healthy and says, hey doc, I mean, there's something that I've read about it, and want to live to be 90 and 100, I would be fully supportive of treatment.
What's your take on ApoB?
ApoB is the lipoprotein that's been associated with laying down of cholesterol and arterial walls. And so it is important. And there are studies that look at ApoB and they actually go, maybe it's even a little more predictive than LDL. So it's not wrong and it would be of interest, but it's not part of the sort of the format of testing. Nothing wrong with it. It's helpful, but most of the data and specifically the guidelines are based on LDL.
So it's kind of like the size, lipid size, more not ready for prime time, more still research.
Yep, exactly.
I think we are well over time. I'm trying to see if there are any other questions, and no one's raised their hand. I think that's all the questions. And yeah, I think that's it. I think we've hit most of the, if not all the questions. Thanks again, Dr. Sadur, for a great talk. And thanks everybody for attending, and thank you to the Cherokee Health Clinic for sponsoring this talk. If your health clinic wants to sponsor a talk, please contact Kristen Talbot. You can choose the topic, the date, the time, the speaker. MAVEN Project would be more than happy to facilitate additional presentations on endocrine topics or any other topic that is of interest and of need for your staff. Thanks again, everybody. Have a good rest of your day. Thanks, Dr. Sadur.
Thank you so much.